The ankle and foot examination. As with all examinations, it begins with an inspection, just looking from front on to begin with, looking for any obvious deformities, swelling, skin changes, or any scars which may be suggestive of any surgery. We then start to look at the back. Here we can see the Achilles tendons and any swelling of the calf, and again any deformities. From the side point of view, as we are looking here, we're looking at the right foot here, trying to look at the arch of the foot. Again, looking for any flat-footedness, which this patient has a small degree of flat-footedness, which might affect on the impact of their walking or running. Again, it's important to compare both sides. Again, we're looking for the arch of the foot. We can then move on to doing a few different tests. Walking on tiptoes, which might be suggestive of nerve damage, and walking on the heels as well. What might be relevant in the patient when we're looking at the foot examination is looking for any foot drop, which might be suggestive of any nerve entrapment or compression more superiorly as well. We can then get the patient to step on tiptoes directly in front of us to look for any abnormalities. We then move on to palpation, looking for any heat changes, any swelling, deformities, and looking for any change in sensation. Again, we feel the calf, looking to make sure it's soft and non-tender. It may be swollen in cases of DVTs. It's also important to inspect the sole of the foot, looking for any ulcers or scars which may occur especially in diabetic foots. We then go on to feeling the actual structures of the foot, feeling around the calf and then the ankle, feeling the medial and lateral malleoli, the anterior ligament of the ankle, and then feeling the actual tarsal bones of the foot. I then palpate each toe individually, looking for any bogginess and fusion which may be suggestive of any inflammatory or arthritic diseases. We then feel the Achilles tendon in particular, and it's important to feel the heel of the foot as well. Here I palpate specifically the heel, and then also feel around the other foot, trying to elicit any pain, and also feel for any bunions, which you can obviously see and may also feel as well. Patients may have reduced sensations in patients with diabetic foots, so it's important to also look as much as possible and look between the toes. Bogginess and effusion can occur, as we said, in inflammatory diseases, but osteoarthritis tends to be a more mechanical sort of pain as well. Again, we feel all the structures, try and feel any feel muscular, and again, feel for sensation, feel for the dorsalis pedis pulses. It's important to feel pulses, and the posterior tibialis pulses as well are important to feel. These may be decreased in ischemic limbs, and also to make sure sensation is present, which may occur or reduce in diabetic foots. We then move on to movements: dorsiflexion, plantar flexion of the foot, inversion and eversion of around the ankle as well. We then move on to the toes, dorsiflexing and plantar flexing the toes are important movements to do. On examination, we can passively move it, flexion and extension, as well as eversion and inversion as well. Comparing both sides as well, always to make sure there's no reducement in movement, or to make sure there's no pain at all on examination. We also get to plantar and dorsiflex against resistance, and in particular, we can test for the big toe, testing flexor hallucis longus and extensor hallucis longus as well. We can then invert and evert the foot against resistance. We can also test different muscles, such as the common the peroneal longus and brevis for eversion, and tibialis posterior for inversion. We then get the patient to sit on their knees and test for the Achilles tendons. Here, we feel along the Achilles tendons looking for any masses, which might suggest any rupture, and then we can squeeze the calf looking for any foot movement. If there's no foot movement down the bottom, it would suggest that the Achilles tendon is injured or ruptured in this sort of situation. There are no obvious abnormalities in this patient. Finally, we can move on to our functional tests for this patient. Looking from a side point of view, we can do calf raises, which would be also important as well. And that completes our examination of the ankle and foot. For full extra tests, we could also examine the knee and also do neurological assessments.